All right. I'm Jennifer Dineen, for those of you I haven't met. I'm from the University of Connecticut, and I'm here to share some work being done by a team that includes Kerri Raissan, also from UConn, Damion Grasso, who's at UConn Health or Medical School, and Mitchell Doucette from Johns Hopkins University. I'm sharing our project Gun Talk, identifying the facilitators and barriers to physician-initiated conversations regarding securing firearms. A project that is just getting underway in terms of we're approaching data collection. So I'm happy to have your insights and as well as your questions at the end of the presentation. Let me just actually change slides. Okay, before I get into the project, I want to stop and thank the New Jersey Center on Gun Violence Research at Rutgers as both being the sponsors of this event and hosting the event that lets us share our good work, but also for funding this project. They've been great supporters and partners so far. Our talk has our project has three main aims. First, we want to understand physicians' identified barriers and facilitators to having conversations with their patients proactively concerning secure firearm storage. And we include extreme risk protection orders in that conversation. I'm going to tell you a little bit about that soon. Second, to understand if and how identified barriers and facilitators might vary throughout a patient's life course. So are those barriers or facilitators identified by OBGYNs, for example, who might be caring for a mom and their newborn, differ from those faced by barriers and differ by those faced by pediatricians, and then those faced by general practitioners. And then third, we want to understand if and how behavioral, normative, and control beliefs towards secure storage and ergo conversation vary among doctors in areas with differing political environments. As I mentioned, we're early on in this project. We've developed the instrument. We have a source for sample and data collection identified. So we're in the finalizing and testing the instrument phase. So first, I want to talk about how we think about secure firearm storage and get to how we include ERBO in that conversation. Our team thinks about securing firearms in a way that protects children and adults from harming themselves or others with firearms, with the goal of preventing things like unintentional shootings, mass shootings, gun crimes, and firearm suicide. Storing firearms locked, unloaded, and separate from ammunition is one way to do that. Another way to secure a firearm would be to remove the firearm from a home, either voluntarily or via ERPO, where a person is at immediate risk to injure themselves or others with a firearm. So, why secure firearm storage? Well, secure storage has the potential to prevent both intentional and unintentional injury. We also know that secure storage behaviors, practices, or a voluntary removal will require a gun owner to engage in certain behaviors. So regardless of the legislative context that a person is living in or a physician is practicing in, for these practices to be successful, we need voluntary behaviors on the part of a gun owner. In national surveys, researchers have found that half of firearm owners stored their firearms in a safe manner, defined as unloaded and locked away. And what's great about secure firearm storage is that best practices are supported by both gun owners and non-gun owners. So there's a lot of agreement on what it means to have a weapon secured. And secure storage has benefits, we know from research. So we've seen from research that there's a demonstrated decreased risk for self-harm injuries among adolescents when firearms are stored securely as a result of physician counseling. We also have seen that child access prevention or CAP laws have beneficial effects on unintentional injuries among small children, and they reduce intentional self-harm among older adolescents. And then secure storage can also help to prevent guns from being stolen which would make them diverted into illegal markets and used in gun crimes often. Similarly, extreme risk protection orders have been found to have some benefits in these areas. There's a potential for a reduction in gun suicides. We've seen that demonstrated in state-level studies in Connecticut and Indiana. One study estimated that one life is saved for every 10 to 20 ERPO orders issued. There's some mixed evidence, but some evidence that ERPO may reduce firearm murder rates. And we've seen ERPOs are successful in cases where violence was threatened with a firearm. When I first started, I started talking about the physician-initiated anticipatory guidance or medical education. So this is the part of a doctor's visit, typically a well visit, where the physician is giving guidance on general potential risks or hazards, which change varied on the patient's life stage in the life course. So for a child, it might be around conversations around bike helmets and swimming lessons. For adults, it might anticipatory guidance might cover things like cancer screening or fall risks with older adults. So the literature shows that when physicians initiate anticipatory guidance, that's a mouthful, or medical education on particular areas, we've seen fewer home accidents, fewer falls, and fewer auto passenger injuries. They've also been shown to reduce negative outcomes, including the number of hospitalizations when addressing chronic disease management. And so our thought is to see if and how we can increase the frequency of those conversations. The literature has looked at this a little bit, but there's some ways we're looking differently or expanding. What we do know is that studies have demonstrated, as I mentioned, a decreased risk for self-harm injuries among adolescents. Oh, I think I went in the wrong direction. Well, let me just pick up from here. Basically, an understanding of physician-identified facilitators and barriers for these conversations taking place in an office setting is one area where the literature falls short. So we know that these conversations, we know physicians support the idea of these conversations. As you can see in the second bullet, we know the conversations are very rare. They're happening fewer than 25% of the time. And we also know that there isn't an increase, like despite interventions and research in this area, we haven't seen the rates of these conversations increase over the past 3 decades. So our team has done a project similar, but not exactly like this, previously, where we only interviewed physicians with a general practice identification. So physicians who identified as general practitioners, we conducted about 18 interviews, qualitative interviews, and we asked about the extent to which they had proactive conversations about firearm safety, their comfort level, and what they saw as the major impediments to those conversations and what they thought might increase those conversations. So this paper, the findings from this study are under review right now, but generally physicians lack the time necessary to provide adequate guidance, and their perception of risk for gun-related injury could be a barrier to having the conversation. Physicians were pretty clear that a lack of screening equaled a lack of conversation. So if it didn't come up on as part of the electronic health record, the conversation didn't tend to happen. Billing may be a mechanism that facilitates such conversations, so being able to bill to insurance companies for this kinds of anticipatory guidance, which is available in other types of guidance. And participants are looking for more training, both in their medical school education, but also in CMEs. And while physicians said the social or political context wasn't a barrier to the conversation, they also mentioned the social and political context when they were discussing if and when they had these conversations. So to extend prior work, both ours and others, we are going to be conducting 36 in-depth qualitative interviews with New Jersey practicing physicians. The physicians will be recruited from 2 separate panels, the Schlesinger Group Physicians Panel and the Logit Group's panel of physicians. Physicians in this study will represent 3 areas. So while we will include general practitioners as well, we will also be talking to OBGYNs and pediatricians. These are all doctors in the state of New Jersey. We're going to attempt to stratify by county level. I'll talk about that in a bit. That we have a stratification plan that we're going to implement with the hope of exploring different political contexts within the state of New Jersey, but our ability to do that successfully is going to be sample dependent. And the interviews will again last about 45 to 60 minutes, and they'll happen via Zoom. So here's our potential county stratification. In an effort to explore physicians in different political contexts, we have 2 stratifications, one in which the county voters and their vote in the last presidential election was majority Democrat, and the other where it was either majority Republican or unaffiliated. So happy to get thoughts on that as well. Our interview topics, as I said, we have a draft guide that's pretty well developed, but we are still refining, and we need to do a little bit more testing on it. But it looks at the prevention education as part of daily practice. So how much of the physician's interactions with patients fall in this anticipatory guidance category. It asks about attitudes and behaviors related to delivering preventative care, and then goes into firearm secure storage conversations as part of preventative care, their comfort with them, their willingness to have them, and their typical practice of doing so. And then similarly, conversations about ERPO, and then asking physicians to identify situations where ERPO counseling may take place and facilitators and barriers to ERPO counseling that might be different from general firearm secure storage conversations. Okay, so that is my project, or our project, really. There's 4 of us in a nutshell. I'm happy to take questions. And I can stop sharing as well. I will put my email in the chat in case I'll just. Okay. You're welcome to email thoughts or ideas as well. All right. And if there are no questions, you're also welcome to jump to another session. All right. Since there are no questions, I'm going to log off. Thank you all. And if you think of anything that might be of help, please send it by email. Oh, we have one more. Are there any steps being taken to enroll doctors? So we are not enrolling physicians specifically. Right now, what we're doing is recruiting physicians randomly from two panels. The two panels are national panels, but they have sufficient sample in New Jersey to support this project. Eventually, one thing I didn't say, so thank you for your question, is that this work, along with our previous work, so one thing we'd like to do, we're going to take this work, we're going to take the previous study I mentioned and future work we're doing with physicians, and we want to test if the identified facilitators and barriers hold up across physicians nationally and hold up or vary across specialties, staying specifically with physicians and specialties that do preventative care. And then we will, from those identified facilitators and barriers that hold up and are most common, we will work to develop an intervention, and then do a study, test that intervention, implement it, and do an evaluation. Our hope is to gain information that makes this part of the general practice, and that could include and will include investigating screening procedures and the determination of what gets included and what doesn't. Well, thanks for the question. I appreciate it. All right, everyone, have a great afternoon and enjoy the rest of the sessions.